Hi, Casey.
You like the Scandinavian stars.
They're not hearing me. I'm hearing them, they're not hearing me.
Maybe he has it.
Yeah, like, he probably ate the most out of everyone. I also have had those. He actually comes
How
pretty
many we
second.
have?
My name.
20.
Ooh, pretty good.
Okay.
Ariana's on.
So,
20 people.
yeah, we did the online part of our biggest call.
Probably. Are people on our unit there? Doris.
All right, guys. Hold the conversation. At 11 on mute, because we will just tell them that we are just waiting 5 minutes, okay? Tell me when you're ready.
No.
Yes.
You're good.
That person is way too much.
You're not.
Way too much. I don't know. I know that girl told a correction and enough.
It's still excellent.
I think you're good.
It was at midnight.
Good night, everyone, and welcome to Nursing Grand Rounds. My name is Perla Roberts, and I have my peer, Karen Young. We will be hosting Nursing Grand Rounds, and our presenters are Christina and Angelina. We will begin in 5 minutes, so just be patient as other individuals are just walking in. For those of you online, you must participate in person in order to receive the certificate, and you have to be on camera and stay for the duration of the presentation. You will receive 5 clinical ladder points, and this will occur after you complete the survey that I will send you. So check your email sometime tomorrow, you'll see, and just complete the survey, and it would verify that you did attend. Thank you. So we'll begin shortly.
Hi, everyone. My name's Angelina and this is Christina. Can you guys hear us good?
Yes. Yes, we can hear you.
Yes.
All right. Today we will be talking about cerebral edema, what it is, why it happens, and most importantly, how we as nurses can help manage it. We'll go over both medical treatments and practical nursing interventions that you might use across different units.
Cerebral edema happens when fluid builds up in the brain tissue. This swelling increases intracranial pressure, which can reduce blood flow and oxygen to the brain, something we call impaired cerebral perfusion. We categorize edema in two ways, localized or diffuse. Localized edema is when the swelling is focused to one area, like around the stroke or brain tumor. So the patient might show weakness or numbness in a specific part of the body. Diffuse edema spreads more broadly across the brain, often after something like hypoxia, and leads to overall changes in the consciousness rather than just one specific deficit. As nurses, knowing the difference between both of them helps us anticipate which signs to watch for and where interventions are most needed. Cerebral edema is a major contributor to what we call secondary brain injury. That's the damage that develops after the initial insults like a trauma or stroke. The swelling itself is part of the brain's response to that injury. The secondary injury can make things worse by causing more swelling, reducing blood flow to the brain, lowering oxygen levels, and triggering inflammation, and of course, increasing intracranial pressure. All of these factors together can significantly affect the patient's outcome, which is why close monitoring and early interventions are so important.
Okay, so cerebral edema can cerebral edema can develop in different ways depending on the underlying problem. Vasogenic edema happens when the blood-brain barrier is disrupted, such as in trauma, tumors, or inflammation, causing fluid to leak into the spaces around brain cells. Another type is cytotoxic edema, which occurs when the cells themselves swell, usually after hypoxia or ischemia, like after a stroke or cardiac arrest. Interstitial edema happens when the cerebrospinal fluid flow is blocked, as in hydrocephalus, leading to fluid buildup. Osmotic edema develops when there's a low sodium level or other osmotic imbalance, which draws fluid into the brain tissue. Each type affects the brain differently, but all can raise ICP and contribute to secondary brain injury. Recognizing the type helps guide both medical treatments and nursing care.
The brain contains All right. Now that we know what cerebral edema is, let's talk about why ICP matters. When the brain swells, it has nowhere to expand inside the skull. This increases the intracranial pressure, which can reduce blood flow to the brain tissue. That means less oxygen, which can further more injury. High ICP can lead to herniation, where parts of the brain shift dangerously, and this is life-threatening and can require immediate action. So understanding and monitoring ICP isn't just a number on the monitor, it's directly tied to a patient's survival and outcomes. That's why as nurses, we focus so much on early recognition, monitoring, and rapid response.
This will be about normal ICP physiology. Under normal circumstances, intracranial pressure or ICP ranges from about 7 to 15 millimeters of mercury in adults. The brain maintains a delicate balance.
You want to watch? And you're dying for your TV.
Just sit mute.
I know you're dying to watch your TV, right?
Those of you online, can you kindly mute your phones? Thank you, appreciate it.
All right, we'll pick up where we left off. The brain maintains a delicate balance between its three main components, which are brain tissue, blood, and cerebrospinal fluid. The Monroe-Kelly doctrine explains that the skull is rigid, so if one of the components increases, the others must decrease to keep pressure stable. If we had a patient who had a traumatic brain injury, what would happen? The blood section might increase in this case, so the skull would have no other space for the CSF and brain tissue. So there would be an increase in pressure, aka an increase in ICP. Understanding normal ICP is important because when cerebral edema develops, this balance is disrupted. Even a small increase in fluid can rapidly raise ICP, impair perfusion, and lead to secondary injury.
We'll talk about cerebral spinal fluid flow. So the brain has four ventricles, which are interconnected spaces that produce and circulate cerebral spinal fluid, or CSF. So CSF flows from the lateral ventricles into the third ventricle, down the cerebral aqueduct to the fourth ventricle. Finally, it goes to the subarachnoid space and gets reabsorbed there. The CSF is being made constantly and reabsorbed at all times, even when we don't know it. CSF acts as a cushion, protecting the brain spinal cord while also removing waste and helps maintain normal ICP. When this flow is blocked, like in hydrocephalus or from swelling caused by cerebral edema, fluid can build up, leading to interstitial edema and increased ICP. Understanding CSF flow helps nurses anticipate how edema or obstruction can worsen a patient's neurological status and guides interventions like monitoring and positioning.
Okay, we're going to talk about the causes and risk factors. Now that we've talked about what cerebral edema is and how it develops, let's go over the most common causes we see in practice. The primary causes are things like traumatic brain injury, stroke, tumors, or infections such as meningitis or encephalitis. These directly affect the brain tissue and trigger swelling at the site of injury. Then we have secondary causes, which happen when something outside the brain causes it to swell. For example, hypoxia after a cardiac arrest, or hepatic or renal failure, leading to metabolic buildup, or even hyponatremia and fluid overload, which can shift fluid into the brain. Understanding these triggers helps us to connect the dots when our patients start showing neuro changes. Not every case of swelling comes from a direct brain injury. Sometimes the cause is metabolic, systemic, or even iatrogenic.
We're going to talk about the clinical manifestations. So recognizing the early signs of cerebral edema can make all the difference, especially for nurses at the bedside who are often the first to notice subtle changes. Early on, patients might complain of a headache, nausea, or vomiting. You might notice they seem a little restless, irritable, or just off. These subtle mental changes are usually the first clue that the ICP is starting to rise. You can also tell with the pupils they become unequal or sluggish to react. As pressure increases, we start to see progressive signs like decreased responsiveness, motor weakness, or abnormal posturing. These vital signs might also begin to shift. For example, you might see a widening pulse pressure or changes in the respiratory pattern. Late signs are much more serious. We talk about Cushing's triad. That's where you have high blood pressure, low heart rate, and irregular breathing. It tells us the brainstem is under significant pressure. At this point, patients can lose brainstem reflexes and require immediate intervention. The key takeaway for nurses is to trust your gut when you feel like something's off. And early recognition and quick communication with neuro and the critical care team can literally save a life.
All right, we're going to talk about the diagnostic tools and monitoring that we do. These are things that we typically see in NSCO. Once we start suspecting cerebral edema based on clinical signs, the next step is confirming it and keeping a close eye on the patient's pressure and neuro status. Our go-to imaging is usually a CAT scan since it's fast and can quickly show swelling, bleeding, or midline shift. If we need more detail, we'll go to an MRI, which gives a clearer picture of tissue damage. For patients with severe brain injury in the ICU, we often use ICP monitoring. Like we said before, normal ICP is between 7 and 15 millimeters of mercury, but anything sustained above 20 to 22 millimeters of mercury is concerning. It's not just about the number, though. Trends over time are what really tell us the story and what's going on with the patient. And of course, as nurses, our neuro assessments are just as critical as the monitors. Checking the level of consciousness, pupils, and other motor responses frequently, and noting even small changes is key. A GCS drop of even 1 or 2 points can be an early red flag that swelling is progressing.
Now we're going to talk about treatment and management. I know we have a lot on the slide. We're going to try to demonstrate a few things too. So once cerebral edema is identified, management depends on the severity and the cause. So medically, we often use osmotic therapy. We use mannitol or hypertonic saline. This pulls out the fluid out of the brain tissue. Mannitol is usually the first line that we give. In the neuro ICU, we typically have these bags. The concentration is 100 grams and 500 mLs. When the mannitol is given, it is up to the provider how much they want to give. They usually want to give a half a gram to a full gram per kilogram. When you're in a crisis like this, it might be confusing when the provider just yells out, give 68 grams of mannitol. So when you're trying to figure out in your head how many mLs to put in the pump, we usually do quick math that we learned in nursing school, desired over have. So if you have a 68 kilogram patient, you're going to put 68 over 100 and then multiply that by 500. So you'll get your mLs to put in the pump. Two things to remember when you're giving mannitol is just to check the bag. The bags do have crystals in it. It's basically just salt water. So it will crystallize. You just want to make sure that there's no crystals when you're priming the bag. The other thing to remember is to put a filter on your line. So the filter helps stop those little crystals that you might not be able to see in the bag with your own eye. So you just connect the filter to the bottom of the priming tube, the tubing. So it filters through this little filter any crystals that could go through. Yeah. What else? Okay.
Another med that providers like to use on our unit is 23.4%. This is 23.4 grams of sodium chloride per 100 milliliters of water. This is a very potent hypertonic that can be given during cerebral edema crisis. This medication needs to be given by a provider. This medication should only go through central access, but if it is emergent, then it can go peripherally. This medication works by drastically pulling the water out of the brain cells even faster and also expands the blood volume, which can be helpful if the patient is hypotensive. For that reason, this medication must be pushed over 5 minutes. This ensures the patient's blood pressure doesn't drastically change.
Another med that we can use is 2% and 3% sodium chloride solutions. Now, typically, these are ordered standing. These are ordered standing usually after the patient gets mannitol. So if you're giving that, they usually want to start them on 2% at 50 mLs an hour or something like that. There is cases where they want to give 3% as a bolus, as opposed to giving mannitol or 23.4%. That one is kind of the same guidelines as 23.4%. The provider must push it, and it must be through central access unless it's an emergency. Ideally, when they want to start the 2%, 3% is just to keep their sodium levels higher. When we have patients in our ICU, we usually keep all their sodiums to like 145 to 150, I would say. Following these administrations, it's really important to like monitor their electrolytes. So we usually send our BMPs, Q6, Q8, like just very often, just that way we're looking at their sodiums. Yeah.
Sedation and analgesia can help lower metabolic demand, which can reduce ICP. In acute situations, short-term hyperventilation can temporarily lower ICP by causing cerebral vasoconstriction. Diuretics like Lasix are also used sometimes. Surgical interventions are reserved for more severe cases. A decompressive craniectomy involves removing a portion of the skull so the brain has room to swell safely. An external ventricular drain, or EVD, can remove excess CSF and allow direct ICP monitoring. Understanding these treatments helps us anticipate patient needs and respond quickly. Small interventions can make a big difference.
On the slide, you can see like where typically if they're getting a decompressive cranie, that's kind of the shape of the bone flap that they take off. So if they do take it off, like they'll let us know, and we'll put a sign above the bed, like we don't want to move the patients and lay them on that side because there is no brain, there's no bone flap. So you want to protect the brain. And then on the right side, we have like the drains that we have in the patients. The bottom one is like one in action. There would be blood in that little canister, and it drains into the bag. So complications and prognosis. So even with prompt treatment, cerebral edema can lead to serious complications. One of the most feared is brain herniation. This can be fatal if it's not managed immediately. Persistent high ICPs can also reduce cerebral blood flow, causing ischemia or infarction. Other complications can include seizures, long-term neurological deficits, like trouble with speech, movement, or cognition, or even systemic effects such as pulmonary edema or kidney injury, especially if aggressive osmotic therapy is used. The patient's prognosis depends on several factors: the severity of the original brain injury, how quickly we recognize and manage the increased ICP, the patient's age, and any underlying health issues. As nurses, early recognition, frequent assessments, and timely communication with the team can make a real difference in these outcomes.
All right, we're gonna go a little bit more now into the nursing management side of this again. As nurses caring for patients with cerebral edema, we do much more than monitor numbers. We support the whole patient and their family. Clinically, we start with frequent neurological assessments and watch the ICP trends closely. Safety is also important, so we definitely want to prevent falls or injury as part of our daily care. All of our patients have fall wristbands on, and if they're out of bed, we put them with the non-slip socks. We manage ICP and physiological needs by elevating the head of bed, administering osmotic therapy carefully, monitoring electrolytes, and providing sedation or analgesia as needed to reduce stress on the brain. Equally important is emotional support. Families may be scared and confused, so taking time to explain the treatments in simpler terms, providing reassurance, and encouraging questions can help them feel included and supported. Finally, strong communication and collaboration with the entire healthcare team ensures timely interventions that both patient and family needs are met. Our presence, knowledge, and empathy can really make a difference in outcomes and family experience.
So some of our key takeaways, to wrap up, cerebral edema is a serious complication that can follow many brain injuries. Early recognition and prompt action are key. As nurses, we play a critical role monitoring neurological status, watching ICP trends, and administering therapy safely. We always want to make sure we keep a safe environment for the patient as well. But it's not just about numbers. Providing emotional support, educating families, and other reassurance is just as important. Small acts of empathy can help reduce fear and build trust with the family and patient.
Finally, working closely with the entire healthcare team ensures interventions happen quickly and effectively, which can significantly improve outcomes. Remember, our role combines critical thinking, technical skill, and compassion, all of which are essential when caring for patients with cerebral edema.
Questions?
Any questions?
The 3.4 so to the peripheral, you need a central. Is it for a long term or a short term?
Like when you need the central line?
On the slide, it says, you can use it big, a peripheral.
Yeah.
If you were to give it like another dose of it, then you would probably want to
Yeah.
do it through a central, and you wouldn't want to give 2 doses for
Yeah.
the peripheral IV.
Usually once you give it through the IV usually isn't that good afterwards anyway.
It may or may not all be actually in.
Yeah. But usually if the patient is getting that, we will try to like place a central access just because the patient might not be doing so well at that point. So usually it's followed.
Even for a long term, like.
No, 23.4% is like given once, and then like we will take them for CAT scan, see if it
Oh,
reduced their swelling.
the volume.
It's usually like 100 mLs, 150, like they'll do like a small amount like that over the hour.
You talked about the filter. What is the size of the filter and does it come with the IV bag?
The filter is a 0.2 micron filter. It's separate, so that's why you have to remember to grab it when you grab your tubing. That's in a separate area.
And then after you give the mannitol, you want to flush that IV site at least twice, because similar to the 23.4%, it's a little hard on the vein and you don't want it to like crystallize. And if the like mannitol drips anywhere, like you can see like there will be like salt like all over the floor, like little
Yeah.
drops of like salt. It's
Yeah.
like white all over. So
And then you also mentioned the crystals. So if we see crystals, we don't use that.
Yeah.
No.
yeah.
If there's any crystals, we cannot use the bag because it's no good. We don't want to see any crystals, but the filter is like your second line, just in case there is any crystals that you do see.
For individuals like outside of the ICU setting,
Mhm.
what would be the signs and symptoms the nurses should look for?
There you go.
I would say just like typically like the first thing, like I guess sometimes your patient will just seem like a little bit more sleepy than normal. And then if you do a neuro exam with them, there will be things that would be off of than they were before. Like if they were full strength before, maybe they'd be weaker on one side or they'd be weaker on their arms or their legs. And then like things that we look for, typically we'll look for pupil changes. Like if our patient is intubated or sedated and we can't ask them questions, if their pupils become anechoic, then we know that there's probably an issue.
Yeah. And even like the opposite too, if they get restless, like you're
Headaches, right?
headache.
Yeah.
Yeah,
Vomiting.
it's really like I feel like you get to know your patient, and if you feel like they're a little off, like trust your gut that something's wrong. I feel like in NSU we all are really like on top of our patients, and we can like like detect like the smallest little change that like might be going on, but it helps with early recognition.
You also mentioned early intervention for herniation. So what intervention at that point? Because somehow I always think, oh, if the brain is herniating, it's done, they're done. But what would be the intervention? Because that's like a critical point.
So usually when we do suspect herniation, we'll give mannitol or 23.4%. That's like our first line. We'll usually give that and then try to get to the patient to CAT scan as quick as we can. That's really what we give first.
So I guess the aim is to kind of reduce the swelling as much as possible.
Yeah.
Right.
So like sometimes they'll put them on the 2% or 3% prophylactically before they have too much swelling to try to like minimize it before it becomes, a full-blown crisis. But usually in crisis times, we will give mannitol and 23.4%.
And if that doesn't work, then
Then if it doesn't work, they can see if they're a surgical candidate and they'll take them for the decompressive crani. Yeah.
In terms of the flap, what's the long-term risk for the patient? Is it ever repairable after it's done? And what's the long-term risk?
Yeah, so sometimes when they take off the brain or the skull flap, the bone flap, they're able to save it and they put it in the patient's abdomen. But that's only in certain scenarios. We definitely see that. That's in the minority. Typically, it's discarded after it's taken off. Similar to like if a patient had head trauma, like in an accident or something. Usually it's fractured or something, so they can't save it. But then they'll have no bone flap. And then whenever they're out of bed from then on, without the bone flap, they need to be in a helmet that they get a prescription for. And then eventually they come back and get a cranioplasty and they put like a artificial plate in their head. Like usually I would say within like 3 months they come back, like after rehab for a little bit.
So usually you'll see like if the patients do have the decompressive crani, the point of it is so the brain can swell out and it won't be constricted by the skull. So sometimes you'll see like their one side of their heads are very puffy because there is no bone flap, so it's kind of like pushing out that way. So then after a few months when they come back for their cranioplasty, it'll be like a big dent in their head
Yeah.
because
very
there's
soft.
no swelling anymore. So then once they get the bone flap placed back on, it looks normal.
Yeah.
Yeah. Anything else? Any other questions? Thanks, guys.
very nice.
Just before you go, one other thing, you said hypoventilation usually decrease the metabolic demand, right? So tell us about the metabolic demand, how it can be negative and how do you achieve hypoventilation?
Yeah. It's hyperventilation. So with the hyperventilation, it helps with the metabolic demand where it vasoconstricts. So it helps with the oxygen delivery. With the oxygen delivery. They don't usually like to do it in the ICU for too long because in turn it is worse for the patient.
Feels that feel.
Yeah, it's not the best thing to do for them. So they'll usually try to take them to surgery or anything like that before they keep them on that for too long.
So I'm imagining like you would have them like on Nimbex
Yeah.
and stuff like that, just paralyzed and then just like full ventilator control, something like that.
Yeah,
right?
that does happen in some cases. Like if it's really severe, whatever's going on, they will paralyze them to try to like rest their body to focus on more of their other issues at the time. And then once we work through those things, then they can come back.
Do you have a question down there? That's a deep conversation. Hey, down there, guys,
Having a meeting down
tell us
there.
about the brain.
Y'all can meet up afterwards.
Any other questions?
Yeah, can you guys just like redo the entire presentation?
Well, you could do a little.
We'll send you the slides.
Great work. Thanks.
Thank you so much.
Thank you. Thank you. Thank you.
I just mute it. The food.
Oh, you were so busy.
Yeah, hey, patients needed me. Chest pain, corona.
Oh,
Yeah, come on, man.
everybody signed in?
Yeah.
The sign in sheet.